Myself, Dr. Kamini Mittal. I am teaching as guest faculty in Center of Food Technology, University of Allahabad. I am presenting before you Module 11, that is the Access to Safe Abortion Part 1, which is related to MTP Act and its provision. This is part of paper 8, which is a paper on women and health, and this has been written by Ms. Bhuvneshwari Sunil of TISS, Mumbai. We will be discussing here certain issues like the need for abortion legislation, the abortion law in India, the Medical Termination of Pregnancy Act, certain grey areas of the MTP Act, draft amendment of the MTP Act of 2014, followed by conclusion. Starting with need for legalizing abortion. What is the real need? Unsafe abortion leads to suffering and deaths of several women. To improve access to abortion care, legislation of abortion was emphasized. Now, abortion remains a contentious issue which raises social, political, moral, legal and ethical concerns. However, a restrictive abortion law signifies violation of women's human rights. At present, 74 countries allow abortion without restriction as to reason or on broad grounds. On the other hand, in many parts of the world, powerful anti-abortion and anti-contraception movements are backed by Christian orthodoxy and right-wing political force. Regarding abortion law in India, during British rule, abortion was a criminal offence except to save life of a woman, according to IPC 1860 and IPC 1898. In India, legislation of abortion was a government initiative, whereas in the Western world, it was initiated due to the feminist movement. In 1971, based on the recommendation of the Shantilal Shah Committee report of 1966, the Medical Termination of Pregnancy Act, that is the MTP Act, was passed. In 1972 again, it was enforced in all states except a few states and union territories. In 1975, the rules and regulation of the Act were formed. Then in 2003, the Act was amended mainly to decentralize regulation of abortion care to the district level and encourage registration of abortion facilities and to minimize delays. The primary reason to pass the MTP Act was to address the ill effects of abortions conducted by non-qualified, untrained and ill-equipped medical practitioners under unhygienic conditions. The MTP Act in India guides us as to when, where and under what conditions abortions are allowed. The MTP Rules and Regulation 1975 define the criteria and procedures for approval of an abortion facility, procedures for consent, keeping records and reports, and also ensuring confidentiality. There are certain grey areas of the MTP Act. Firstly, over medicalization. What is it? The authority of providing abortion services is placed on the physician. The Act necessitates the authorization of one doctor in pregnancies up to 12 weeks and 2 doctors in pregnancies between 12 to 20 weeks. This is over medicalization. While wide range of reason could affect the mental and physical health of the woman, it remains with the doctor to opine in good faith the need for a termination of a pregnancy. The differences in interpretation of law lead to denial of abortion services for the vulnerable women. For example, the act describing married actually could be misinterpreted to deny services to unmarried or single women. Abortion policy within the rights framework emphasizes not only the women's right to seek safe abortion, but also her right to access safe abortion services, as well as information about the availability of such services and the consequent responsibility of the state to provide these services. Now, differing interpretation and a provider-dependent policy affect the vulnerable women and also result in denial of abortion care to women in need of these services. Now, Section 3 of the Act refers to the MTP in married women context. Although the law does not explicitly deny provision of abortion care to women outside the marital context like unmarried women, widows, separated, etc., the law can be misinterpreted. Now, the other gray area is regulation of health facilities. Act recognizes public health institutions as potential providers of abortion care services, and therefore they are exempted to obtain approval or certification that is part of the regulatory process. Now, due to lack of regulatory process at the government facilities, abortion services are mostly defunct and lack transparency. Lack of these services actually hampers the accessibility and affordability to safe abortion services. It leads women to seek services from the private sector. Lack of adequate public investment and effective implementation has affected affordable access to services. Now, apart from the rules and regulation mentioned in the Act, certain states have imposed additional layers of controls and unnecessary regulations that has affected the facilitation of abortion services in private sector. Further, the difficulty in monitoring the mushrooming private sector accompanied by the regulatory process has led to lack of ethics in medical practice and absence of self-regulation amongst the profession itself. Regarding quality of abortion care, government facilities have been acknowledged in many studies to be inadequate providers of abortion services due to lack of infrastructure facilities, due to lack of trained manpower, etc. And on the other hand, there is a profit motivated, business driven private sector, which is characterized by often unnecessary diagnostic, medical and surgical practices or exorbitant charges for the services. Now, in terms of quality of care, both the private and government sectors rely largely on D&C technology for early abortion, with a few providers reportedly using vacuum aspiration, which is a much better technique. There are certain misconceptions of legal procedures. Both among the providers and women, there is low awareness and misconception about the law. The law does not require spousal or any third party consent for a termination of pregnancy. Only in case of minor or mentally ill, consent of guardian is required. Often women avoid going to public institutions for abortion because of fear of covert or overt coercion for post-abortion contraceptive use or forceful sterilization if they have 2 living children. Whereas the comprehensive abortion guidelines emphasize the need for providing counseling services for contraception, extended care of up to 6 weeks after abortion, and management of abortion complications. These are the recommendations. All this compels women to go to private sector, and in many instances to unsafe abortion providers too. There is a call for action. There is need to create more qualified providers to improve access even in the rural areas. There is a need to simplify the certification process for the private sector. At the same time, also it requires the same process requirements for the public institutions too, which are up till now exempted from them. There is need to link policy with technological developments. Quality abortion care must be the vision of policymakers and the implementers. What is the call for amendment of the MTP Act 2014? The Ministry of Health and Family Welfare in October 2014 released a draft of the MTP Amendment Bill 2014 with certain proposed changes to the existing MTP Act. Firstly, expanding access to abortion care by including mid-level and non-allopathic healthcare providers. Secondly, first trimester abortion will be considered a matter of the woman's choice and a physician's opinion will no longer be required. Thirdly, for the second trimester abortions, instead of 2 doctors, 1 doctor's consent is proposed. Fourthly, explicitly abortion care for unmarried women is to be mentioned, accompanied by ensuring privacy. Fifthly, the gestational limit for abortion will be extended from 20 to 24 weeks, and in addition, abortion will be provided for specific fetal anomalies after this period. And lastly, clarification of the legal status of medical and surgical abortions is also proposed. So we can conclude that the draft MTP Bill 2014 gives a possibility to change the abortion discourse in India by making it women-centric abortion law in India. Thank you.